In this session, I'd like to review the issue of smoking and podiatric surgery, and also really smoking and wound healing, period. Several years ago, I was chairing a panel for a podcast at ACFAS, and I posed the question as to whether or not the surgeons on the panel, all of whom were accomplished and thought leaders in our profession, would interdict performing surgery in someone who was a smoker. And I was surprised to see how many of the panel members, in fact all of them, who stated that they would proceed with the performance of surgery even in someone who is a smoker. I did find that to be somewhat surprising, period. We know that with reference to surgery as well as wound healing, smoking is associated with a number of complications. We know studies have indicated problematic soft tissue as well as bone healing. There is increased risk of postoperative infection. In the case of osteotomies and fractures and arthrodesis in particular, an increased risk of delayed union and non-union or pseudoarthrosis. And we know that most of this is attributable to the fact that smoking is associated with increased occlusive disease, increased risk of vascular thrombosis because of platelet adhesions, the inducement of vasoconstriction, increased tissue ischemia. Now, these are local factors superimposed on increased anesthesia risk, increased cardiopulmonary risks in general due to smoking. So we have situations such as this, in which a patient who is a heavy smoker underwent a Lapidus procedure. Smoking was not discontinued, and this resulted in a substantial wound breakdown and considerable delay in healing. It seems difficult to argue that smoking has deleterious effects on bone healing and wound healing. This particular study looked at the risk of non-union associated with ankle joint arthrodesis, showing that we have almost a fourfold risk of non-union for an ankle fusion in smokers versus non-smokers. Similarly, with subtalar joint arthrodesis, we know that there is a 20 times higher rate of non-union in smokers versus non-smokers in performance of subtalar joint arthrodesis. This was a study looking at the Austin bunionectomy, showing that even for osteotomies that are rather uncomplicated, smokers have a 42% increased healing time for the Austin bunionectomy, and even secondhand smokers had some slight delay in healing when exposed to secondhand smoke. Bobby Mendocino and Catanzariti out of Pittsburgh showed in their evaluation of factors operative for delayed healing of ankle fractures that cigarette smoking as well as obesity and diabetes were the leading factors responsible for delayed healing of ankle fractures. When we make efforts to have patients discontinue smoking, those that do report increased pain following surgery. Most smokers in general will continue to smoke up to the day of surgery. This particular study looked at the use of patient-controlled analgesia, PCA units, and smokers most definitely had more hits on the PCA than did non-smokers, and those who discontinued smoking also showed significant increase in use of the PCA. So when we do discontinue smoking, or we have smokers who are being treated post-operatively, they do seem to have increased demands for analgesia. The effects on nicotine on osteotomies and arthrodesis and fracture healing result in decreased strength of bone, so that we have to have protective weight bearing a bit longer than normal. There is reduced incorporation of grafts when grafts are utilized, and all of this seems to be related to decreased vascular ingrowth due to the fact that smoking results in increased thrombosis as well as vasoconstriction. Most have argued that the effects of smoking are reversed after about 2 weeks discontinuing smoking, and that's been the general standard to recommend abstinence for approximately 2 weeks. When smoking continues, there's decreased vascularity, as we noted, and also, as you'd imagine, decreased recovery of growth factors in studies. Looking at fracture healing, such as tibial shaft fractures, here again, we know that smokers have between 3 and 18 times the risk of abnormal bone healing following tibial fractures. So that when we look at the smoker who is going to be undergoing lower extremity surgery, we know that there are increased cardiopulmonary risks. There's increased risk for infection, increased risk of surgical failure. These patients have a higher revision rate. It's generally recommended that their smoking be stopped at least 2 weeks prior to surgery. We also want to discontinue caffeine use in these patients and continue abstinence of smoking through the perioperative period. Looking at other factors, for example, transmetatarsal amputation failure, this particular study looked at factors responsible for failed versus successful TMA, and in addition to factors such as elevated hemoglobin A1C, chronicity to ulceration, or the need for postoperative debridement, which predicted failure, smoking was also found to be a significant risk for failure of TMAs to heal. We know that smoke contains a number of toxic factors, over 4,000 constituents, the most important of which are generally felt to be nicotine, hydrogen cyanide, and carbon monoxide. Nicotine in particular is a very strong vasoconstrictor. It increases platelet adhesiveness, and as a result we have decreased vascular flow to the bone or soft tissues. Nicotine impairs fibroblast activity, decreased wound healing, decreased collagen synthesis, and impaired macrophage activity, as a result of which we have persistence of necrotic tissue and increased risk for infection. We have decreased oxygenation of tissues also due to carbon monoxide and hydrogen cyanide. And again, these are problems that are superimposed on the cardiopulmonary issues that one can see following any surgery, and certainly larger procedures such as ankle joint arthrodesis or ankle joint arthroplasty. DVT and pulmonary embolism is one that is often cited as a potential consequence of smoking. We know that smoking in the non-surgical patient is associated with increased risk of DVT and pulmonary embolism, yet some studies have noted that paradoxically smoking can be associated with a decreased risk of DVT and pulmonary embolism in the surgical patient as opposed to the non-surgical patient. So what do we do about this? Well, prior to surgery, it's important to advise patients to discontinue smoking and to advise patients of the cardiopulmonary, soft tissue, bone healing risks, as well as the increased risk for surgical failure. Patients need to assume responsibility should they elect to continue smoking. There should be an agreement by the patient to discontinue smoking, at least verbally, and patients should be advised to discontinue smoking 2 weeks prior to surgery. All of this needs to be documented, and it needs to be documented prior to surgery, that the patient was advised to discontinue smoking, that the patient was advised that smoking can increase their likelihood of poor outcome, procedure failure, infection, and so forth. It is not standard of care to refuse to do surgery on smokers, and I think most panels that I have participated in, and the general opinion throughout the profession, is that it is not considered malpractice to go ahead and do surgery on a smoker. However, we are taking on patients that are at increased risk for complications. Therefore, I think it's important to document a stronger indication for surgery, offer the patient an appropriate referral back to their primary care physician for smoking cessation, and I think it's important to perform an appropriate vascular evaluation and document the presence of adequate vascular flow before proceeding with surgery. And it's important to have all of this documented. If we look at impaired wound healing in patients who discontinue smoking, we know that the maximum effect generally peaks at around 8 to 11 weeks, where smokers, or I should say patients who were smokers and discontinue smoking, begin to show an incidence of impaired wound healing about equivalent to that of non-smokers. And when we look at the variety of complications that can occur in a smoker versus a non-smoker, the literature overwhelmingly demonstrates that indeed complication rates are higher in smokers. So when we look at a case such as this, a patient who comes in and is complaining of night pain, is ulcerating between the great toe and second toe, from a bunion with compression pain between the great toe and second toe. The patient has a history of smoking 1/2 pack of cigarettes per day. The patient has other factors associated with vascular disease or increased risk of vascular disease, such as hypertension. In this type of patient, it's sort of important to ascertain their vascular status and document the adequacy of their vascular status, particularly when you have atypical signs and symptoms, such as a patient with an ulcerating callus between the great toe and second toe, and the patient who has night pain, which certainly is not typical for bunions. This particular case did end, unfortunately, with wound failure and amputation. This particular survey was conducted among foot and ankle orthopedic surgeons. It noted that 16% of foot and ankle surgeons do not document whether or not their patients smoked. Only 9% actually documented patients were warned of the effects of smoking or included that in their consent form. But interestingly, almost 1 in 4 surgeons noted that in the presence of smoking, they frequently altered their planned surgical approach as a result of the potential effects of smoking. Most patients do smoke, as noted, up to the day of surgery. This particular study showed that indeed smokers have a higher infection rate than do non-smokers. And interestingly, ex-smokers had the same increased risk of infections in this particular study as did non-smokers. And following foot surgery, patients were found to have twice the wound healing problems as non-smokers. Another reason it's important to document these matters is because patients frequently forget or deny that they were warned to discontinue smoking. This particular study looked at the ability of patients to recall 11 specific complications that were discussed with the patient prior to surgery in their consent form. On average, patients could only recall 1 out of 11 warnings or discussions of complications that they had been provided prior to surgery. So it's very important that we document all of this because patients have difficulty recalling this. We want to note whether the patient never smoked, are they a former smoker, and if they are a smoker, how much do they smoke, and how long have they smoked. The perioperative notes should also include a reminder to discontinue smoking, and this should be included in the discharge instructions. And frequently I'll also include this in the operative note or discharge summary, that the patient was again warned to discontinue smoking. Following surgery, we do see these patients for their follow-up care. And it's important to document whether or not the patient did or did not stop smoking. If they have not stopped smoking, it is important to repeat the warnings regarding smoking and document this, that indeed the patient was again reminded that they had been warned about smoking, they are not complying with requests to do so, and that they need to be warned again of the potential complications associated with this. I think the worst case scenario when it comes to litigation is when there's a less than optimal surgery, a delayed union or a non-union, and when the complication, whether it's an infection or poor wound healing or poor osseous healing, failure to fuse, whatever, becomes obvious. And then all of a sudden, a note appears in the chart that attributes this poor outcome to smoking. And if you go back in the chart prior to this attribution of the poor healing to the smoking, we see nothing in the chart. We see no warning by the doctor that the patient should discontinue smoking. We see no indication the doctor was at all concerned about the smoking until the complication was recognized. And this sometimes is a difficult problem to defend, not impossible, but difficult, because what you hear from the plaintiff's attorney is very simple. They go, well, doctor, you're saying that this non-union or this infection, the poor wound healing, was due to smoking. And you're going to say, yes, it was. You've documented that in your chart. And you go, well, then if you knew that, why wasn't the patient warned in advance to discontinue smoking? Why did you not advise the patient that this would be the case? Because it's more likely than not that the patient's going to sit there and say, had I known, I certainly would have given up smoking. So documentation becomes important. Over the years, I've seen a number of cases in which smoking was an operative factor in surgical or wound healing failure. This is one example of such a case that went to court. We did prevail with a defense verdict. This was a 45-year-old female who presented with painful warts on the distal plantar aspect of the foot, generally below the second and third metatarsal heads. At the time she had consulted with her podiatrist, she had a history of having had the warts treated for a 2-year period of time, and really, in looking through the records, this patient had had a literal array of procedures performed, excisions, various topicals, and so forth, and unfortunately these warts remained painful and recalcitrant to care. And this had gone on for 2 years. Her medical history was significant for fibromyalgia, chronic low back pain, and alcohol abuse, and her prior pathology reports did verify the fact that she did have warts. She had undergone treatment with 5-fluorouracil, cryotherapy, a variety of topical acids, oral medications such as Tagamet, and had undergone several excisions of her warts, all with recurrence. Her examination really was otherwise unremarkable, and this included an unremarkable neurologic or vascular status. Given her failure to have responded to a plethora of seemingly appropriate therapies and her continued pain, it was elected to proceed with bleomycin injection. Following the treatment with bleomycin, she developed rather severe blistering and inflammation, which took quite some weeks to heal, but eventually she did heal and the warts did resolve. Unfortunately, she then developed a recurrence of her warts. The doctor did provide the patient with a full written and oral consent discussing the potential side effects of bleomycin, and the doctor did follow standard protocols in utilizing the clindamycin, and this included the potential for swelling, medication reaction, pain, complex regional pain syndrome, and so forth. Because of the recurrence, the patient was given a second round of bleomycin injections, and after this she developed the Raynaud's phenomena of the toes in her involved foot. Now, Raynaud's is a known potential complication utilizing bleomycin. She had continuing pain and swelling and developed what was diagnosed as Raynaud's phenomena. And again, this is a known potential complication in the use of bleomycin. She was referred by the podiatrist to a vascular surgeon. In fact, she saw a series of 3 different vascular surgeons, all of whom diagnosed her with Raynaud's phenomena secondary to the bleomycin, and the vascular surgeons all recommended discontinuation of smoking due to the fact that she had the Raynaud's and felt she had no requirement for any additional therapy other than discontinuing the smoking. She refused to discontinue smoking. She continued to experience Raynaud's with pain and eventually underwent transmetatarsal amputation of her forefoot following bleomycin injections for plantar warts. The plaintiff retained an attorney who retained an expert. This particular expert is one of the individuals who lists themselves on the various services as being available to testify. And the plaintiff's expert stated that because she was a smoker, that this was equivalent to having peripheral arterial disease, and that smoking by definition per se implied the presence of vascular disease, even though there was no documentation in the chart to suggest that she did indeed have vascular disease. Bleomycin injections in the periphery for the treatment of warts are contraindicated in the presence of vascular disease, and therefore it was the position of the plaintiff's expert that by definition the patient was a smoker, therefore per se had vascular disease, and therefore bleomycin was contraindicated. After seeing the first vascular doctor who stated that he believed she had Raynaud's disease from the bleomycin, she then informed the subsequent vascular doctors that she had been, quote, diagnosed with Raynaud's, close quote, and the other doctors presumed that this diagnosis preceded the use of the bleomycin. So it was the basic position of the plaintiff that vascular studies should have been performed even though there was no evidence or history to suggest vascular disease. And the plaintiff's expert further suggested, as an aside, that ascertaining a history of Raynaud's disease should be obtained in all patients, particularly smokers, since smoking is a known cause of PAD and should have contraindicated the use of the bleomycin. Now, fortunately, the defendant doctor had an excellent attorney and a wise jury, and a defense verdict was returned. So in summary, many patients smoke, and it is not the standard of care to refuse surgical intervention in a smoker. I think some judgment's required, and we know that certain procedures such as ankle arthrodesis procedures in general, osteotomies, are associated with delayed healing or increased risks of non-union in smokers. We know there are increased risks of infection, poor soft tissue healing, and certainly increased risk of cardiovascular complications. So smokers need to be advised of this, and this needs to be documented. And patients need to know that while you're not going to deny them surgery, the fact is that they are going to have to accept the fact that should they not follow your advice and discontinue smoking for at least 2 weeks prior to surgery, that they will accept increased risk of failure. I think it's important to document this conversation. It's important to document it in their discharge orders, and it's important to follow them post-operatively and to document their adherence or non-adherence to the recommendations. And again, it's probably best to at least re-advise the patient at least one other time regarding the potential deleterious effects of smoking on their healing period. Hopefully this will be a bit helpful to you in your practice, and thank you for joining us at the Center for Podiatric Education.